Hi, I'm Chris Cox. I'm a thoracic radiologist at Creighton University, and I'm just going to talk to you a little bit today about basics of evaluating for pulmonary embolism on CTA. So on an evaluation of a CT angiogram for pulmonary embolism, whether the indication is rule out PE or some other respiratory symptom where you're considering pulmonary embolism, there are some specifics that I would recommend just for every single study. And some of these specifically are study quality, pulmonary artery filling defects, pulmonary parenchymal changes, right to left ventricular ratio, and then just as an extra consideration, main pulmonary artery diameter. So here I'm showing you a select image through the main pulmonary artery, and on it I have measured the density of the main pulmonary artery to adequately be able to visualize a pulmonary artery filling defect, which in an acute pulmonary embolism is going to be around 30 to 40 Hounsfield units. We would like the density of the contrast in the surrounding blood of the pulmonary artery to be sufficiently dense to outline that. So in general, we want the average Hounsfield units in the main pulmonary artery to measure about 200 Hounsfield units. Here I've measured this great example that has an average Hounsfield unit of 434. A consideration of something that can mimic pulmonary embolism is motion artifact. Here, this is an example of cardiac motion where you see some motion in the adjacent left ventricle as demonstrated by kind of a double outline of the left mediastinum. But also you see in the adjacent vessel that I've highlighted here with a yellow arrow as being almost in duplicate, like a shadow of itself. And what that can do is it can produce an appearance of a low attenuation filling defect within a vessel. So anytime you're looking at the pulmonary arteries and soft tissue windows, you'd want to flip it to a lung window to see if there's motion artifact at that level, to avoid mischaracterizing a normal vessel as one containing pulmonary embolism. Now moving on to identifying pulmonary emboli, this is an example where I've got two different pulmonary artery filling defects, one in a subsegmental pulmonary artery highlighted by the green arrow, which is a near occlusive pulmonary artery filling defect. The adjacent vessel in the right lower lobe has a central pulmonary artery filling defect, so a non-occlusive pulmonary embolism highlighted by the orange arrow. Along with this, you would want to look at all the adjacent slices to ensure that you're looking at a vessel that is pulmonary artery as opposed to a pulmonary vein. Often you will hear discussion of saddle pulmonary emboli. So here I'm showing you a large central pulmonary embolism highlighted by a red arrow, which is crossing the bifurcation of the main pulmonary artery into the right and left pulmonary arteries. There are also additional pulmonary artery filling defects in the branches of the right and left pulmonary arteries. So this would be a large pulmonary embolism. When you have an occlusive pulmonary embolism, you can develop a peripheral infarct. So what we're seeing here is a peripheral consolidation secondary to that infarct. Generally, infarcts have associated hemorrhage with them, which causes a filling of the pulmonary of the bronchi. So you will not generally see air bronchograms. Also, you tend to get a central kind of bubbly lucency to these peripheral consolidations on CT. On chest radiograph, this would appear as a peripheral consolidation, which could look like a pneumonia or even a mass. It should also be noted that, in general, pulmonary embolism that causes an infarct has to be pretty good size because there is two vascular supplies to the pulmonary parenchyma, both pulmonary artery and bronchial arteries. So usually it's a pretty good sized pulmonary embolism that causes infarct. When you have a decent sized pulmonary embolism, you'll want to assess the right ventricular size relative to the left ventricle. We call that the right to left ventricular ratio. So you find the maximum diameter of the right ventricle and you measure that and you compare it to the maximum diameter of the left ventricle. Here I've made both of those measurements on a single axial slice, showing that in this example, the right to left ventricular ratio is less than 1. In a large pulmonary embolism, once it is above 1, then it's suggestive of right heart strain. And then once it crosses the 1.5 threshold, then you have a significant decrease in survival from pulmonary embolism. And then finally, after you've looked at the right ventricle and assessed it for dilation, you also want to consider the main pulmonary artery. The main pulmonary artery generally will not dilate significantly in the acute setting, but if there is chronic increased pulmonary artery pressure, you may get dilation of the main pulmonary artery, as you would see here. And in that setting, you would want to take enlargement of the right heart with a grain of salt, because it may be that there's chronic pulmonary artery hypertension and chronic dilation of the right ventricle. Also, pulmonary emboli in the setting of an enlarged main pulmonary artery, you'd want to consider chronic thromboembolic disease and assess for additional findings which could suggest that. That is my quick run through of basics of assessing for pulmonary embolism. Thank you.